Okay, thanks guys for holding on. Now let us move on to the next session. And it will be a panel discussion where all the questions which we were discussing here will be dealt more into detail from the Indian interest point of view. And to do the panel discussion, I am very pleased to invite Dr. Ramya Upulari. She is the consultant pediatric hemato-oncologist and bone marrow transplant physician at Apollo Chennai. They do cord blood transplants and they do some metabolic transplants, one of the busy centers out of two, three, which do metabolic transplant. So I'm really, really looking forward to have a very, very scintillating panel discussion. And of course, Rob is there to specify all our queries. Thanks, Rob, once again, and over to you, Ramya.
Thank you, sir. And thank you, everyone. And thank you to the organizers of SPCTT for giving me this opportunity. Also, special thanks to all the people who've logged in and listening to this webinar today, considering it's actually Navratri festival that's going on. Today is Ashtami. So everyone, tomorrow is Navami, which is actually Saraswati Puja. So it's a good day today to actually do the webinar because it teaches us and so much more about doing better for our patients in terms of metabolic disorders. Along with Professor Wynn, who has kindly agreed to continue as our expert panelist, I'm very happy to invite the other two panelists for this session, Dr. Pooja Malia, who is a consultant in pediatric hemato-oncology and transplant at Narayana Health City, Bengaluru, and Dr. Priyanshu Mathur, who is a medical geneticist and a professor in the Department of Medical Genetics at SMS Medical College, Jaipur. Welcome, everyone. So, like Dr. Satyendra already mentioned, we'll a lot of points, of course, Dr. Wynn has already covered in his talk, but we'll hopefully have a few more points to discuss. So very quickly, this is a 1-year-old girl, only child. She was diagnosed to have MPS 1. She had normal neurological assessment, normal hearing, normal vision. She underwent a matched unrelated donor transplant, including flu-trio, thiotepa, and ATG. So the beginnings were happy. She's now 7 years now post-transplant, has complete chimerism. She's growing well, goes to school, no obvious neurological or skeletal defect. So to start out, Dr. Pooja, how do we select the right patient for transplant in mucopolysaccharidosis, and what age cutoff do you practice in terms of offering transplant to these children? Dr.
Hello, good
Pooja?
evening, everyone. So first we need to understand whether the transplant is really required in that particular disease, because there are certain transplant sensitive diseases. So the most common indication is mucopolysaccharidosis 1, which is the Hurler syndrome. The other MPS where transplant is also offered is MPS 2, MPS 4A, MPS 6, and MPS 7. There is no role of transplant in MPS 3. So first is the disease. The second is the earlier age at presentation. The earlier age at transplantation has a better outcome. So age definitely plays a part. The next is the genotype of the disease. So the milder the disease, the better and less complicated the child is, the better will be the outcome of transplant. Also a mention about this MPS 4A, because many of these patients do present with respiratory complications. So they have narrowing of airways. They can have they might have repeated infections in the lungs because of this. And I think it has to be individual basis for these patients when we take them up for transplant. If possible, to give a pre-transplant ERT would be beneficial, as EBMT says that if you give around 12 weeks prior to transplant, it will actually lessen the cardiopulmonary complications which are seen in transplant. An ideal situation would be to have a matched family donor who's not a carrier. So that will be the ideal patient for a HSCT. And coming to the age cutoff, so I think EBMT says if a child is like 30 months is their cutoff, but I don't think I can say a cutoff for my center, because it has to be individual patient based. So the youngest patient we have transplanted is 1 year old, and the oldest patient we have transplanted in an MPS 1 would be around 7 years old. So it totally depends upon what is the family's expectations and their current status, neurological status before taking them for transplant. So I don't think I can say a correct age cutoff, but our mean age otherwise has been anywhere between 3 to 5 years. Majority of the patients have been that age.
Okay, thank you, Dr. Pooja. So the second story is of a 2-year-old twin boy and girl. They were twins and both had MPS 1. The twin girl had advanced neurological disease when she came to us, so therefore HSCT was deferred. The boy had normal vision, hearing, or neurological assessment. At that point in time, he had no significant defect. There was a fully matched father, so we went ahead with the flu trio thiotepa protocol. He does even today have complete chimerism. However, within 6 months of transplant, he had deterioration of vision. He had glaucoma with visual impairment. Now he's almost 4 years post transplant. He's gaining other milestones, but he doesn't have vision anymore. So I think this highlights what Professor Wynn, after all his years of experience, I think Professor Wynn can agree that, over time you learn more humility when you see your patients and you do more transplants, which is true. So, did we, he's alive but without vision. So, you know, did we win? I don't know the answer to that. So, Dr. Priyanshu, the role of ERT, Dr. Pooja was mentioning about ERT as a bridge to transplant. So would ERT have helped the above child, number one? And second, how is ERT specifically for MPS available in India, please?
Yeah, thank you. Thank you very much for the question. So, enzyme replacement therapy for MPS1 is available by the name of laronidase. And it's a very crucial to start enzyme replacement therapy before giving hematopoietic stem cell transplantation because it can reduce the progression of the disease. And second important point is there is definitive role. Second important point is the cornea is relatively avascular tissue, and if we can start ERT earlier, so it's high likely that we can reduce the symptoms of blindness. So we can reduce the symptoms.
That's a very good point. So you specifically mentioned that for blindness, ERT, you that's what you mean to say, that for blindness
Yes.
specifically it helps.
Right.
Okay. And it is available, and is it available
Yes.
through pharmacies, or do we have to apply through the rare disease
Right.
program? Yeah.
Right. So ERT is available. So there is a policy, national policy for rare disease, which was developed in 2021. Under this policy, so Government of India is supporting up to 50 lakh rupees financial assistance for patients suffering from various lysosomal storage disorder and other disorders. So under that category, we can get the enzyme replacement therapy, but we need to apply through the Center of Excellences, which are 15 in number across the country, and the cost will be borne by the Government of India.
So it is not possible for families to purchase it if they wish to. I'm not saying people would, but if they wish, it's not. Is it possible or not possible?
So they can procure, but the cost is
Of
very
course.
high. So
Yeah,
it's
yeah.
around 40 to 80 lakhs rupees for a 10 kg child. So the cost
Per
will be,
year. Is
yeah,
that per
it's
year, you
per
think?
year. It's per
Per
year.
year.
Per year.
Yeah. Yeah. So, Professor Bin, that's the status we are in India. Of course, now we have a lot of public-private partnerships and governmental support for these sort of conditions. So that's great. So, as Dr. Mathur mentioned, um, that because of the support, there are a lot more children who are getting access to enzyme replacement therapy. So, as a routine at your center, do you give ERT to all patients with MPS 1 before transplant, please, Professor Win?
We do, but it's an interesting thing. When we looked across Europe and looked at the difference in outcome between kids that received enzyme and kids that didn't, that we can't see an outcome. So personally, I wouldn't worry too much if you can't give enzyme. I'd just get on a transplant. There is no doubt that if you give enzyme replacement therapy, the kids feel better. So their airways are better. The one we would definitely give enzyme is for the child that's presenting with cardiomyopathy and with
Okay.
very poor cardiac function with very low fractional shortening. We would give them prolonged enzyme therapy to make them able to tolerate the transplant. So maybe many months, 6 months or whatever. They usually present very early in life, so they're young. So you've got that time. I don't recognize the blindness. I don't know what that's about, and I would just wonder whether that's something else. So the the predominant ophthalmic manifestation of Hurler is corneal clouding. There
Cornea.
is some retinal disease. It takes a while. So I can't see why the child would be blind. And then, it seems an odd thing to me, unless it was in, hydrocephalus or some other cause. But so I wouldn't, and I don't think you should worry that you missed an opportunity to save that child's life. By the vision by not giving enzyme. I mean, so when we look at the kids with Hurler syndrome and we've given ERT, a lot of them will have very high level antibodies by the time the transplant actually happens. So the because it's a foreign protein to the Hurler kids, and so it may well be that it's not as useful. And in the kids with gene therapy, it may be that using enzymes sensitizes their immune system against the gene, so that the gene modified cells don't take. We'll just have to see. So I think in summary, we do give enzyme. As soon as we get engraftment, we stop the enzyme. But I think when I think about what matters for a Hurler child before transplant, I think it's getting to transplant soon. Yes, the ERT will help the airway, but actually once you condition a baby, the chemotherapy helps the airway by reducing the adenoids and the tonsils and things like that. So I would those would be my thoughts on enzyme, even though.
And you did mention in your talk about age not being an absolute cutoff,
Yeah,
but
so
in your practice, what do you do?
our median age for transplant is about 16 months. So if we look at the kids in the UK, the median age at transplant is 16 months. So it's not as young as we'd like. It may be changed by newborn screening, and in lots of parts of the world, newborn screening is happening, and so that is helping kids, I think. Be diagnosed early. And if we do get a very young child, we will transplant them very young. So we usually, will be transplanted them between 6 and 8 weeks, and it's the same protocol that we would use. So we transplant them when we get them. For the older child presenting over 2 and even over 3, difficult decision, but we might do those because the transplant's very effective at preventing the somatic manifestations of the disease. And even if the neurocognitive performance might not be as good as if we transplanted at the age of 6 months, it's still not bad. So we would think long and hard about that one, although they are more difficult transplants to do in the older kid. But yeah, we would always offer transplant to kids under the age of 2, and sometimes we think about the older ones and
Discuss with the families accordingly.
Yeah, of course.
Thank you. Moving on to another condition, which we do see, Professor Bin started his talk by saying these are not as rare as we think anymore. They really aren't, because I think there's more awareness about this. And I think more of, if I can say so, metabolic pediatricians, I think, are the voice for these patients. And they are the ones now who are probably referring to a transplant center more than what they would earlier. And I think we have 2 metabolic pediatricians in this panel today, Dr. Mathur and Dr. Sunita. So I would say that the referrals are increasing, and therefore probably we see more of these patients. So this is an 8-year-old boy diagnosed to have X-linked adrenoleukodystrophy. He's the only child. The LACE score was 8. There was no matched family or a MUD donor. So again, when it was just 8, in general, the cutoff is known to be 8 to decide about whether you should transplant or not. And as soon as he came, we spoke to the family, and because they said this is our only child and we want to give him the chance, we went ahead with a haplotransplant from the father. He engrafted, had complete chimerism. He was well up to day plus 60. However, after day plus 60, he had loss of graft. And again, alluding to what Professor Wynn spoke in his talk, that probably earlier deaths that you had mentioned, or earlier outcome being poor, was probably more of graft rejection. And I hope today, with haplos also in India, since it's very commonly done, we are improving in terms of engraftment and preventing graft rejection by improving our own learning curve and our techniques. However, the moment he lost his graft, rapid deterioration, within 4 weeks, he died. So the other is a 6-year-old boy, no complaints. Elder sibling was evaluated for progressive neuroregression. He was found to have X-linked adrenoleukodystrophy. The sibling was screened only because the eldest sibling was already affected. The younger child was positive for the gene mutation. The Lay score was 2, no matched donors. He also underwent a very similar haplotransplant, although I think we gave him some pre-transplant immunosuppression to prevent rejection against the previous case. He's now almost 4 years actually post-transplant. He's well, no neuroregression, goes to school. So, Dr. Priyanshu, what is the spectrum of X-linked ALD, especially in India, and when do we choose, is the right time for transplant? And if we are not transplanting, how frequently would you recommend for an MRI brain?
Right. So, so there are four main phenotypes of X-linked adrenoleukodystrophy, and it's a remarkably wide spectrum of clinical presentation, which we can see even within the same family members. So the first type is childhood cerebral adrenoleukodystrophy. This is the most severe and devastating form, and this is the primary target for hematopoietic stem cell transplantation. The age of presentation is between 4 to 10 years of age. The second type is myeloneuropathy. So this is basically adult onset form and usually appears in 20 to 30 years of age group. Third form is Addison's only, so it causes only adrenal insufficiency, and fourth can be asymptomatic. So asymptomatic presentation, similar example like 6 years old patient, boy was almost asymptomatic in as you mentioned in this case. And the best time, the decision to proceed with HSCT is not based on the clinical symptoms, but it is based on the MRI findings. So the trigger is the MRI. So whenever we are getting any change in the MRI, we should consider the hematopoietic stem cell transplantation. So we can say that any new active inflammatory lesion in the brain white matter should point toward the need of the hematopoietic stem cell transplantation. So there is a window of opportunity. So there is definitive role of MRI in this patient because the clinical features can vary, and MRI brain is recommended if first MRI is normal between 3 to 12 years of age. We can do 6 monthly MRI. And for children more than 12 years of age, we can recommend yearly MRI. If there are symptoms, we can go for earlier MRI.
Thank you, Dr. Mathur. Dr. Pooja, what is the importance of Lay score? All of us take this as a cutoff to counsel families as well, right?
Yeah. So, Lewis score is generally a 34-point severity scale based on the brain MRI of the findings of X-linked adrenoleukodystrophy. And it will help us to evaluate the extent of the demyelination as well as atrophy which has happened. So we take a cutoff of less than 8 for a patient with having a Lewis score of less than 8 who's eligible for transplant. So if you have a low Lewis score, there is better overall survival. In patients who have a higher Lewis score, it is actually told that advanced diseases, the bone marrow transplant actually can accelerate the inflammatory demyelination and neurological deterioration.
Okay, thank you, Dr. Pooja. So, what is the cutoff that you take at your center, please, to decide?
We take it at 8.
At 8,
less
yeah,
than
that's
8, yes.
generally what is recommended. Professor
Yes.
Win, would you agree with our discussion on this?
Yeah, I mean, it's pretty advanced that, and we always get ourselves in a bit of a tiz here. We do. I mean, I think for this, it's easier. It's better to do the younger the better, and not the younger the less. The lower the score, the better. So we would usually be serially following boys. So even where you've got a kindred where the boy is an older boy is affected, his brothers may be unaffected. So I think what's important, if I think about XALD in a newly diagnosed boy with advanced disease, and 8's quite advanced, the things that matter to me, first of all, if we're going to transplant that boy, do it quickly and counsel them. And the disease is progressing the whole time. So that's the first thing. Second thing, make sure that you're thinking about all the other potential boys in that kindred. So mum's sisters and her sons and this sort of thing. So just so that you can begin to find asymptomatic boys, so that you can begin to screen them and do MRs. So I think yes, think about the index case and get on with the transplant, and but also be looking for brothers and mothers, sons and the like to find other affected boys. Um, and when we transplant, there's no dose effect here. So we would use a carrier donor. We would even use a carrier sister. So she's only got one copy of the gene, half of that will be inactivated. So we're not worried here about enzyme relationship. It's not like lysosomal disease, so we'd use a carrier sister, we'd get on with it. I think this transplant is mainly about the intensity of the immune suppression around the transplant. And the more advanced disease you are, the more likely you are to have regression during transplant. And I've seen some horrible things with doing advanced disease. I mean, they may not be that high, but you're always tempted when you see a boy in front of you at the age of 5 and 6, because they look better than their scan, to do it. And I would just caution against that, because when you look at those boys 10, 20 years later, they're awful.
Oh,
They're not living an independent life. So, yeah, be careful about doing advanced disease. If you are transplanting, get on with it quickly. We tend to use busulfan to get it into the brain. I'm not sure about treosulfan doing that. Treosulfan therapy probably does, but we don't have enough evidence around that. So we tend
sure.
to use busulfan-based conditioning and use the best available donor and get on with it, and then
So,
remember the rest of the family.
yes, Professor Bin. So the other point I wanted to ask you actually is that two of our ALD patients post-transplant, about 3 months post-transplant, both of them had refractory autoimmune hemolytic anemia. Is that something that you see in your cohort?
You've seen what?
Autoimmune hemolytic anemia, refractory.
I don't think that's probably just unlucky. We certainly see more immune cytopenia when we're using cord blood as the donor cell source, but I don't recognize autoimmune hemolytic anemia as being a particular side effect of.
Maybe ALD, not
Yeah.
specifically related.
And of course, for the metabolic pediatricians, then obviously, finding adrenal failure in young boys, this will be one
Yes,
of the commonest cause of it. And again, that's then about starting the screening and identifying other boys that might be affected. I mean, the tragedy of when a boy, we've seen it so many times when a boy presents with advanced disease, and yet, mum's brother or something had something not dissimilar, and we just haven't managed to communicate the genetic nature of this disease to everyone.
sure. Moving on. So this is about MLD. I think Professor Wynn just touched upon metachromatic leukodystrophy, but we do see these cases as well. So this is a 2-year-old boy, previous sibling death with MLD, and therefore the family came early actually for the transplant. He's been on follow-up now for almost 7-8 years, and he's doing well, neurologically well. However, at the time of the transplant, his peripheral neuropathy was not significant at all. He was just 2 years old when he came to us. However, over time, it has progressed and it is quite severe today. So, what are the comorbidities that one would expect with MLD, Dr. Pooja?
Yeah, so as you rightly pointed out, peripheral neuropathy is definitely one, which HSCT does not help for. The other thing is they can have seizure disorders, epilepsy, optic atrophies. They can have bowel and bladder incontinence, at times metabolic acidosis. Many of them can present with gallbladder diseases and hypo and hypertonia. So these are some of the comorbidities seen with the MLDs.
Okay. And which of these, Professor Wynn, do you think does improve with the transplant? Because in MPS, we see that a lot of comorbidities do recover or regress post-transplant, including cardiac or corneal clouding, etc. But in MLD, do you reckon that that doesn't happen?
I think the peripheral neuropathy doesn't get better. Yeah. So I mean, the tragedy of some of the kids with MLD is that they have decent neurocognitive function, I think, with a standard transplant, but they're disabled by their peripheral neuropathy, and so I think with MLD, when I think about MLD, I would distinguish different genotype phenotypes. So you've got the late infantile form where we would do gene therapy now, and then you've got the juvenile, and then late juvenile and adult forms, and they're all just milder. As you go older, the presentation is later because they've got residual enzyme, and so we still make I think with all MLD these days, we would be using gene therapy because it corrects the peripheral neuropathy.
Okay.
and but it's so expensive.
Yes. Sure. Dr. Mathur, what are the predictors of survival? So when we have children coming to us for a transplant, do we have certain markers which we can say, okay, let's not transplant this child then?
Yes. So the most important predictor for survival is early treatment in pre-symptomatic stage, which is the most important factor. And second important is the if the disease is late onset, so then the chances of survival is better. So early onset disease, they have a severe, they have a severe, they have more severe, they are more severe, and the chances of survival is less. The second important is residual enzyme activity. So ARSA enzyme activity, if there is a residual activity which is already present in the patient, the chances of survival is better in these patients. Then the early diagnosis by newborn screening. So that is again very important. So we can do HSCT in these patients at earlier ages. Uh, Again, MRI finding is important. There is MLD score which is from 0 to 34. Again, the milder the MLD score, the chances of survival is better. And the few patients with the slower progression of disease, we can have a better survival.
So the residual enzyme level that you mentioned, is that something we can test
Yes,
pre-transplant and know?
yes. So enzyme testing can be done.
So based on the report, if it's zero or whether there is some amount of enzyme, is that what you mean?
Right,
Yeah.
right. So we can also go for a gene testing, genotype. So some genotypes are associated with the residual enzyme activity. So
Okay.
that can help us.
Okay, okay, good, great. That's a good point, and I think Professor Wynn covered this. Now, moving on to Gaucher, as Professor Wynn said, in India especially, Gaucher is a huge number of metabolic disorders are Gaucher in India somehow. So this is a 4-year-old girl, Gaucher's disease. She had splenectomy at 3 years of age. There was no compatible family donor. She underwent a matched unrelated donor. Similarly, a 2-year-old boy with Gaucher, huge, massive splenohepatomegaly, no obvious bony deformities. Both had normal neurological functions. This child underwent a fully matched sibling donor transplant. Both received myeloablative conditioning with flutiothiotepa and ATG, of course, for the child and not for the fully matched sibling. And both the children tolerated chemotherapy well. However, hepatotoxicity was significant in both, as expected. Both had electrolyte disturbances. The first child, who was post-splenectomy, she started engrafting by day plus 10, and she had sudden DAH, diffuse alveolar hemorrhage, and we lost her. The second child, although he had the huge spleen, he had a lot of hypersplenism, a lot of platelet refractoriness, required a lot of blood products. However, he engrafted, and he's now almost 5-6 years post transplant. He's doing well. He's got sustained chimerism. Both the liver and spleen size have come down significantly. And none of these two children had received enzyme replacement therapy because of the various challenges that were involved. Just recently, about a month ago, we did another Gaucher child with a fully matched sibling. He has received a year's worth of enzyme replacement therapy. And, touchwood, his BMT process was not as complicated as these two children were. And, so that's reason enough. So therefore, Dr. Mathur, what are the challenges with ERT for Gaucher in India? And how early should we start ERT in these children once they're diagnosed?
Right. So the foremost challenge is the cost, because it's very costly, and it costs around 40 lakhs rupees for a 10 kg child for a year. So the cost is a big challenge. Second is limited access and availability. So not all center across the country, they are equipped with they are having trained manpower, and they are equipped with the facilities for enzyme replacement therapy. And third is important is lifelong dependency. So ERT should be given lifelong for Gaucher patients. So these are few challenges, and definitely ERT should be started as early as diagnosis is made. And ERT helps in reducing the inflammation inflammation in the body, and it can have benefit in hematopoietic stem cell transplantation, and it also helps in the decreasing in organomegaly. So liver and spleen size decreases rapidly after starting enzyme replacement therapy, then can again benefit if hematopoietic stem cell transplantation done at a later age. So we can say that it enzyme replacement therapy can be used as a bridge to transplant in patient with Gaucher disease.
Thank you. Dr. Pooja, role of splenectomy pre-transplant and BU versus trio in these patients.
So I think the status of the spleen before transplant is very important. If we have frankly not been able to use much of ERT in Indian patients, like we have done transplants for 6 patients, and in that maybe only 2 were had accessibility to ERT. So in the rest of the 2, and in 2 of the patients, we have done splenectomy pre-transplant. So these were children who had massive splenomegaly, had hypersplenism with refractory thrombocytopenia. So in these patients, we did do splenectomy. So I don't think we are able to say which is right and which is wrong. But the only thing is that what we had seen is those patients who did not undergo splenectomy, did not have ERT, but had massive splenomegaly, we did have a very slow or prolonged hematological recovery, which was seen in these patients. Also, for the next question of your best conditioning regimen, so actually, we are not using cord blood transplants in our center. We have done around 34 transplants in generally, I'm talking about whether it is MPS or if you take other lysosomal disorders, maybe probably 40 patients. So majority of our patients have been haploidentical transplants. And in haploidentical transplants, majority of them, we have used the TCR alpha beta depletion kit with CD45RA depletion. So our conditioning regimen initially was busulfan with monitoring of the therapeutic levels, but we have changed to triosulfan based conditioning now. So we are actually using triosulfan, thiotepa, fludarabine with ATG based conditioning for patients because majority of our patients have been haploidentical transplants, and we actually have not seen so much of viral reactivations, which we are actually worried about because we are kind of giving the CD45 RA add back, as well as we have also not seen too much of mixed chimerism and secondary rejection, which we are very much worried about triosulfan. So right now we are using triosulfan based conditioning.
Sure. Yes, Professor Bin, about your more than this, I think you mentioned about the role of splenectomy. I think in the discussion you did mention, but could you reiterate whether Dr. Pooja's point that if we have children with huge spleens, which is very common in India, and features of hypersplenism and no access to ERT, suppose, would we do a splenectomy pre-transplant?
I'm gonna. You know more about this than me, actually. Pooja, you've done much more Gaucher than I have. These were my thoughts on Gaucher. Yes, I think in the old days and from 30, 40 years ago, when a lot of transplants were done and splenectomy was routine, or at least partial splenectomy. But I just couldn't stand in front of you and pretend to be an expert. We would use ERT if we were doing it. We would use triosulfan thiotepa, try and do a match donor transplant. We actually use T-depleting serotherapy, so Campath or ATG, in all patients, even family donors,
Right.
so that we don't get GVHD. So in non-malignant disease, we would use serotherapy in everybody. And again, just to say what I said in my talk, I actually think that this is a good candidate disease for gene therapy, and I think you are a good candidate country to do it in because you have such technologic expertise and universities, and I'd be very happy if anyone wants to email me or collaborate. We can, this isn't difficult medicine, or it's not difficult science. We have the vector, and I'm not suggesting doing anything cheaply or inappropriately. I'm talking about good science and good vector production, but the facts of it are not difficult. The vector's easy. We've got the vector. We just clone in different enzyme genes, and then get proper production. I think it's a good candidate disease, and I think that's the way forward
Sure.
in this, because it works. Transplant works, and and it's cheap relative to a lifelong enzyme, and so it ticks all the boxes. So worth thinking about.
Sure, thank you. Yeah, so I think we'll just cover in the next 2 minutes, 3 minutes, because there's a lot of questions, or there's a lot happening in the chat box actually. So if there's anything that's not covered there, maybe we could take that. So, Dr. Pooja, when should a follow-up MRI and neurological assessment be performed post-transplant in, let's say, an X-linked adrenoleukodystrophy, for example?
First is it's very important to have a comprehensive baseline evaluation before we start for post-transplant. And if we take for adrenoleukodystrophy, it is like if they are asymptomatic, we could do annually once. Or if we have undergone a transplant, we have actually done it 6 months and 1 year. So we have done it 6 monthly once. But a neurological assessment would be around 3 months, every 3 months. If it would be MPS, I would think a baseline evaluation definitely, followed by which you have to do a proper neurological examination with the help of a neurologist, because it's very important, maybe every 3 months, which has to be seen whether there is progression, there is improvement, any cognitive abnormalities, development of hydrocephalus. So, and imaging probably once in 6 months.
Sure. Dr. Mathur, when should we check enzyme levels and if they have suboptimal enzymes, which happens very often, what should be the follow-up in these patients?
Right. So the primary goal of hematopoietic stem cell transplantation is to treat enzyme deficiency and to replace the patient cell with the donor cell, so that we can replenish the missing enzyme. So enzyme testing should be done in these patients around day 100 after post hematopoietic stem cell transplantation, because by that time stable donor engraftment is confirmed in majority of patients. So we can repeat the enzyme levels after 1 year, and we can repeat it earlier if the symptoms reappear. And if we are having suboptimal enzyme levels post hematopoietic stem cell transplantation, so we can switch for alternative therapy. Like we can go for enzyme replacement therapy, or we can again try for the second hematopoietic stem cell transplantation.
Sure. Professor Win, between a fully matched, so this is, I think this will probably be the last question. So between a fully matched mother, who's most likely a carrier, and an unrelated donor, who would be the best donor? And I think
Is
you
this
partially answered this,
is
actually.
this an XLD?
Any, so let's say in the
An
gamut,
XLD, yes.
there were certain metabolic disorders where it was told absolutely no for a carrier, while for certain, it's told it's okay. So can you give us some guidelines regarding that? Because having carrier donors fully matched is a very common thing in India.
So in a lysosomal storage, so these are great questions, and I guess a lot of this is about transplant experience and judgment. In a lysosomal storage disease like HERLA, we would choose a well-matched non-carrier donor. So if we had an unrelated donor, we would do the unrelated coder over the mother who's a match, but a carrier. Now, if we didn't have a well-matched donor, I would use the mother as the carrier. So I think that's the judgment here. So we think for a 10-on-10 unrelated donor, our outcome is going to be just as good as a family donor. So we would use that. But if we didn't have a well-matched unrelated, I think it's legitimate to do a safe donor who is a carrier rather than an unsafe donor who's not a carrier. So that's lysosomal storage diseases. I think less true for Gaucher because it's a macrophage disorder, and as soon as you've engrafted the macrophages, you're okay, and a carrier macrophage is okay. So you're not relying on cross correction in Gaucher so much, and same for Wallman. And in XALD, choose the best match donor. It doesn't matter about carrier status. So we would use a carrier girl, and we should probably publish that because I think partly we've confused the world with this non-carrier business. And definitely in XLD, that doesn't worry me at all using a carrier. Just choose the best donor.
Thank you so much. And thank you to my other esteemed panelists, Professor Win, Dr. Marley, Dr. Pooja, and Dr. Priyanshu for an amazing panel discussion. And I hope we've had some good take-home points for our practical use in India. Over to the organizers, please. Thank you.
Thanks, Ramya. And Professor Win, sorry. Thank you very much. But I have one more question. So let us say there is a child who has got a lowest score around 3, 4, and fortunately has got the access to oral laryngolatazone as well.
We don't use any of that, just transplant them.
Just transplant them. Yeah, thank you very much.
If I may answer this question, laryngolatazone is not yet in the market. It is just an investigation.
Compassionate use, yeah.
Although the trials have been over, and they also say that a candidate for laryngolatazone is the one where there is no matched donor or where HSCT is not possible. So HSCT remains the number one choice.
Yeah, correct. So that's what, yeah. So is there anything, just to conclude all the Professor Win, Dr. Sunita, anything you want to add? Because you have helped a lot today. It's a young country from transplant point of view. A lot of youngsters are there who are running fast. So I just thought, let us put some speed breakers. Anything to conclude with Professor Win and then Dr. Sunita, please.
Yeah, for me, I think that your future will be gene therapy as well as allo. So I think there's two important things. I think gene therapy has a role in this much more than in immunodeficiency because, or even hemoglobinopathy, because in this field, gene therapy transplants are both safer and better. So in immunodeficiency and in hemoglobinopathy, an immunodeficiency transplant is never going to be better than an allo. It's just going to be safer. Whereas here, because you can modify gene delivery and gene expression, it's going to make it better. So I think it's that message that gene therapy's got a role, but also allo has a role, and I think together we can find a way to make. Gene therapy is struggling in the UK and the US and in Europe because of expense, and I think we need to find a better way of delivering it, maybe a little bit independently of the big pharma companies and things like that, we're a bit stuck there, and that's why I think Gosha is a good model for us to develop together, because I think allo's got a role, but in the end, the gene therapy will have a role here, and India's a good country to think about that because you've got patients, you've got obvious transplant expertise, but you've also got scientific and technological expertise, and with the universities that you've got there. So I think there's a way forward here.
Yeah, thank you, sir. So from the Indian point of view, the only thing I want to say is that we are a big country. We do have a great expertise in this particular procedure of HSCT. What we are lacking is the ideal patients, because we want to catch them young in the early stages. So what we need to focus on is awareness, and to the general pediatricians, to the general population, because by the time they reach you or me, it is really very late. We feel bad about it because we can do something, but then the time has already gone. So we must really focus on the awareness. Obviously, we can't start newborn screening because we are not even at the step 1 of newborn screening. We hardly have a universal coverage for the core, disorders. So let's just focus on creating this awareness. And like I suggested in the chat box, we can all come together and maybe as a project, we can start this HSCT for Gaucher, and that will also create the awareness, and we will have that expertise and experience to go forward with the gene therapy when we are ready. Thank you, Professor Win, and thank you, Satyendra. Thank you, Satya.
Thank you, Professor Win. Thank you, Dr. Sunita. Thank you, Ramya. Thank you, Pooja. Pooja, you are a star. And thank you, Priyanshu, my friend. Thank you, sir, Dr. Satyaprakash Yadav. Thank you, Gaurav. Thank you, everybody. This is a festive day today, but we have learned a lot from the professor. And happy Durgashtami to Professor as well. Thank you very much once again, Professor. And we will get back to you again. Thank you, everyone. Have a wonderful night, and we will meet again next month. Thank you.